my name is Alexis, and I'm going to be doing a presentation for you today on thyroid disease. And I'm actually going to turn that light off because it's glaring on my TV here. Sorry about that. All right, so we're going to first start by talking about the thyroid and exactly what that thyroid is and the pathophysiology behind thyroid disease. So your thyroid is a butterfly-shaped gland that's located on the front of your neck right above your trachea. This gland synthesizes regulating hormones that work within your body to help with your metabolic rate and to regulate that, and also to help with the consumption, the oxygenation consumption in your tissues. And it does that with the help of some hormones. So your hormones that are secreted by your thyroid gland, you have your T3, your T4, and your calcitonin. Calcitonin isn't so much used with thyroid disease, like involved in it. It is a very important part of your body, a very important part of your thyroid gland, but calcitonin just works to remove the calcium levels in your blood. Your T3 actually helps to control your muscles with brain function, heart, digestive functions, things like that. And your T3 and T4, when they work together, they help to increase your metabolic rate, to help regulate that. They make the cells work harder, which is going to make the cells need more energy. And this is what the thyroid secretes. And over here we have your pituitary gland and your hypothalamus, which are also a very, very important part of your thyroid and the whole entire system. But they are located in the brain. So like I said, right here is a bigger picture. It's your pituitary gland and your hypothalamus. And what these two do, they control the thyroid. And whenever they control the thyroid, whenever they feel as though the thyroid hormone levels have dropped, your hypothalamus is going to send a thyroid hormone, like secrete a thyroid stimulating hormone to the pituitary gland. That pituitary gland is going to send, and that hormone that the hypothalamus sends is called TRH. Now, the pituitary gland is going to receive that TRH, and the pituitary gland is going to send it to the thyroid. And it is going to turn it from TRH to TSH. So the hypothalamus will make TRH when it detects the thyroid is low on hormones. The hypothalamus will then send it to the pituitary gland. The pituitary gland is going to send TSH, which stands for thyroid stimulating hormone. And whenever the thyroid gets that, it's going to secrete and it's going to make your T3 and your T4. And then it'll send that T3 and T4 all throughout the body to give the body energy, to help to regulate the metabolic system and rates. However, when your system's a little bit wonky, out of whack, because we know it all happens, then that's when you start to have abnormalities, disorders, diseases, that type of thing with your thyroid. So we'll go over exactly what they are. So you could have hypothyroidism, goiter, hyperthyroidism, sometimes even cancer. And there are two major types of thyroid disease. You will have a congenital disease or an acquired. So a congenital or acquired disease disorder, that is going to happen to your thyroid because, we'll turn this back on and better explain this. Okay, so like I said, your thyroid here, this thyroid is going to secrete T3 and T4. So think of this as a car. Your pituitary gland is going to send your thyroid TSH when your pituitary detects that the thyroid is low. So your pituitary can be your gas can and your thyroid is your car, okay? So when your car is low on gas, your pituitary gland is going to give your thyroid some gas, so TSH, and help to get that T3 and T4 back in here so it can be secreted and put throughout the body to regulate your metabolic rate and help with your breaking down your food and making energy for your body, that kind of thing. Okay? So if your T3 and T4 are low, then your pituitary gland is going to keep screaming, TSH, TSH, you got to fill up. Your gas tank's empty. Fill up, fill up, fill up. So your TSH is going to keep going high because your T3 and T4 is low. So in hypothyroidism, you have a low T3 and T4, and you're going to have a high TSH. Now, the other end of that is if your T3 and T4 are high over here, then you have hyperthyroidism, because your T3 and T4 are good and you're filled up. Your car doesn't need any more gas, so your gas tank isn't working. It's not going to send any TSH because it's not stimulating that you need any for your car. So your pituitary gland doesn't send any TSH. So in hyperthyroidism, your T3 and T4 are going to be high and your TSH is going to be low. So if you think of it this way, T3, T4 high, you have hyper. If it's T3, T4 low, there's hypo because it's low. And that's an easy way to remember that. And we'll go ahead and talk about the congenital hypothyroidism. And this is more prevalent in babies because congenital means that they are born with it, as acquired means that they have to develop it over time. So when you have congenital hypothyroidism that's in a baby, it's very, very, very important to get this detected and treated quickly. So it's detected through a newborn stick, the heel stick that they do. It's mandated through every hospital, state in the United States. They have to get the newborn screening. So when it's detected on the newborn screening, the baby's T3 and T4 are going to be low. The TSH will be high, that type thing. It's going to require them to go see their pediatrician. Maybe if it's even bad enough where they need an endocrinologist, they'll make a referral to an endocrinologist and they will get that help and get levothyroxine, Synthroid, something like that to work as a synthetic T3 and T4 to fill up that thyroid. So hypo, you need T3 and T4, so you're going to put Synthroid in here to fill it up. That's what your gas is going to be for hypo. Your gas is Synthroid or levothyroxine, something to that nature. Signs and symptoms that might develop here with these type of babies that have the congenital hypothyroidism, they might be excessively tired, they might be inactive, poor eating, poor sucking on their bottles, they might have a thick protruding tongue, swollen protruding belly button, they might even, in severe cases, develop condition called craniism, and that is when it's severe, it's super, super, super severe hypothyroidism that they need to get treated now. It's a very serious complication. And if they do not get this, if babies are not treated quickly with hypothyroidism or congenital hypothyroidism, then they can, due to the T3 working with the muscle function and growth, development, it plays a role with your digestive system, your heart, and your mental status, your brain function. These babies can have intellectual disabilities and even develop dwarfism. So acquired hypothyroidism, the most common one is Hashimoto disease. And Hashimoto's disease, it's an autoimmune disorder. So instead of just the normal thyroid panels where you have your T3, T4, and your TSH, you're also going to check their thyroid peroxidase, because that is going to tell you whether or not it is a autoimmune disorder. And this can happen from or it's an increased risk for them to get this condition from radiation exposure. And it affects 7 to 8 times more women than men, but it can affect any age, but most of the time it's around middle adulthood patients. And this is where your body, it attacks your thyroid tissue, and so the tissue dies. So if the tissue is dead, it's not going to produce those hormones anymore. It's going to be low hormone production, which would make your T3 and T4 not being produced, because those are the hormones that are being produced by your thyroid. So other conditions that might develop, it might be something due to radiation, iodine exposure, lithium exposure, the removal of your thyroid gland. It also could be from either your hypothalamus or your pituitary gland having issues secreting their TSH or TRH, and that could lead to hypothyroidism. Manifestations of hypothyroidism, it's going to include hypotension, bradycardia, lethargy, cold intolerance, constipation, weight gain, thin, brittle hair, brittle fingernails, depression. So again, if you think low, hypo, low, then you're feeling down, you're depressed, so your hair might not be fixed, your nails might not be fixed. That's a good way to remember it. So just everything is very low. You might gain weight from eating too much ice cream. That's a nice way to think about it, because you're depressed, which it's your body not metabolizing everything fast enough, so you're gaining weight. It's not actually eating the ice cream, but it's a good way to remember it, is that you're gaining weight, you're not feeling yourself because you're low from the hypo. hyperthyroidism. So laboratory tests that they're going to do, they might, you're going to have a decreased T3, a decreased T4, an increased TSH, and then also maybe anemia they might test, and it could be diagnosed with an ultrasound as well. They might order an ultrasound. Complications, the most major serious complication is myxedema coma, and this is a very serious condition. It's going to have different manifestations such as carpal tunnel syndrome, hypothermia. You might have thickened non-pitting edema of the skin, and you're going to want to maintain a patented airway. Maybe use hydrocortisone, the levothyroxine, and then also you might find hypoglycemia, hyponatremia, hypoxia, prolonged QT waves, that kind of thing with this condition. For hyperthyroidism, you have the most common types are going to be your Graves' disease. And this is the most common, along with thyroid nodules, which also goiters and thyroiditis. And this is whenever your thyroid produces too much T3 and T4, so your TSH is going to be low because it doesn't need to produce. Some clinical manifestations that clinical manifestations that might go along with your Graves' disease. You might have anxiety, tremors, your goiter, bulging eyes. That's a very serious one. And if a patient has this, you're going to want to tape those closed because it's whenever the eye comes out of the orbital socket. Also, thick red skin and rapid or irregular heartbeat. And this is like enlarged goiter. It's showing you a normal versus a hyperthyroidism. Laboratory test for this one, you're going to want to check their T3, their T4, their TSH, and then if it's an autoimmune disorder, again, you're going to check that thyroid peroxidase. And then complications, the most serious complication of hyperthyroidism, it's going to be your thyroid storm. And your thyroid storm is excessively high levels of thyroid hormone with a high mortality rate. So it could be due from infection, stress, DKA. Symptoms might be hypertension, chest pain, dysrhythmias, dyspnea, delirium. Treatments for this, there's different types of medications, but a thyroidectomy might be necessary. And this is where they just remove your thyroid. And so you're going to have to be on lifetime replacement therapy for the rest of your life. But other medications they might use a lot of anti-thyroid medications because you want your thyroid levels to go lower. And there's my references. Thank you.